kind of break this up. I'm going to give more of an overview, a little history, and then we'll get kind of deeper into things with the next group part. I need my glasses so I can see. Again, I'm from Duke University, a lot further away. So ketogenic diet, what is it? I like to call it the ketogenic dietary therapy, which is what they call it in Europe, to separate it from the keto diet that a lot of people are used to doing for losing weight, because it's different. So it's not that kind of diet, and it's also not a natural diet. It's something that has to be monitored. It really stresses the body out, and you need to have close follow-up. And what we're trying to do is teach the brain to live off ketones and not glucose. So you kind of have to allow the ketones to build and be there, but also reduce the glucose so the brain doesn't preferentially eat that. And we know that ketones or other factors related to that can reduce seizures. And if anything you look at, a good dietitian is key. For finding meals, for planning everything, you need a good dietitian. They're hard to find. So history. The thought of ketogenic diet's been around for a long time. Hippocrates described in the 5th century BC of a man becoming seizure-free with complete abstinence from food. There's a biblical reference in Mark saying that prayer and fasting cured seizures. But it wasn't until 1910 where a guy named Conklin, who thought that food had toxins in it, would starve patients with seizures, and he found that they improved. Years later, Dr. Wilder at Mayo Clinic dug deeper and found you didn't have to starve these patients. It's the low carbohydrate that helped, and he coined the term the ketogenic diet, which we use today. But Johns Hopkins, and whenever you look at a ketogenic diet, everything's Johns Hopkins. They're the ones that kind of perfected it and kept it going even to today. In the 1940s, it kind of went away. Nobody was really doing it except Johns Hopkins, and it was probably because there were new medicines. It was also thought not to work. There wasn't enough data out there for people to continue to use it. But it's really in the 1990s when a young man named Charlie Abrams developed intractable epilepsy, and his father is Jim Abrams, who is a writer and director. He did movies like Airplane, things like that. And he took his son to Hopkins, got on the ketogenic diet, and he became seizure-free. And that led to a story on Dateline, and so once it was on TV, everybody knew about it. And then it led to a TV movie called First Do No Harm that Jim Abrams put together. So then it was out in the public. He also started something called Charlie Foundation, which provides information, but it also provides a lot of the tools used by a lot of dietitians for calculating the diet and calories and things like that. There's a European version called Matthew's Friends. So from the early 2000s until now, it's really an accepted therapy for epilepsy. And there are variations, like the modified Atkins diet, low glycemic diet, which we'll talk about in more detail. But there's still a lot of research, education to be done. I still have colleagues that don't believe it works, even though it doesn't. Why do we use it? 30 to 40% of patients who have epilepsy are not completely controlled with medications alone. And after you fail 2 medications, appropriately chosen medications, your chance of meaningful control is less than 5%. So then you have to think of what else can I do? And there are surgical options for some people. You can take something out, or you can put in a device that may control seizures, or you've got the ketogenic diet. There are some disorders where we use it sooner. The big one is GLUT1, and they're going to talk more details. Sometimes in infantile spasms or developmental epileptic encephalopathies. And sometimes we'll use it in seizures that won't stop in the hospital for whatever reason. We'll start it in the hospital. How well does it work? 50% of patients who start the diet will have 50% fewer seizures. So it's not a cure-all, but it can work where sometimes medicines don't work, and it works well with medicines. And 10 to 20% of children may achieve greater than 90% seizure control. And usually you see a response pretty quick. In the first 2 to 4 weeks, you're going to see some response. You may adjust and tweak the diet, but responders respond pretty quickly. When should we think about it? I would say when it's safe and appropriate. The International League Against Epilepsy recommends it after failing 2 medications, again, because the chance of a 3rd one or a 4th one or a 5th one is unlikely to have big benefit. You also need a knowledgeable and eager family and patient because it's a lot of work. It's not the best tasting thing. So kids who are tube fed, it's often easier. So it's not for everyone. It can be very difficult and time consuming preparing meals. You have to measure things, weigh things, think about everything you eat. And then there's monitoring. And when you're on a full ketogenic diet, you have to have regular labs and things to make sure that the diet itself isn't causing problems. There are contraindications, disorders of fat metabolism, carnitine disorders. There's just a group of things that we have to check before you go on the diet. So there are some people that just can't safely be on the diet. Now, how does it work? Well, we know that fatty acids are turned to ketones in the liver. And the big one we monitor is beta-hydroxybutyrate. And ketones easily go into the brain where glucose needs a transporter. So if you have a disorder in that transporter, the GLUT1 disorder, this is the way to treat that. But how the ketones actually work, we don't really know. Because is it the ketones or is it something associated with the ketones? We know that people on the diet, it can increase the inhibitory chemicals in the brain while decreasing the stimulatory chemicals, so that should help seizures. We also know that there may be some neuroprotective effects to it, where it may prevent future seizures because you're not getting constant injury from the chemicals released during seizures. So the diet, it's often effective. It's usually well tolerated. It can be very challenging, and patients need to be monitored, and that's a big thing. We have to make sure that the diet's not hurting you. And it has been looked in other things besides seizures like malignancy and psychiatric disorders. But there's still a lot to learn and a lot of education to be done before I think it's even more mainstream. So I'm going to pass it off to my colleagues.
Hi everyone, I'm Sarah, one of the ketogenic dietitians at CHOC Children's.
And I'm Susan Fong. I'm a pediatric epileptologist at Cincinnati Children's.
And what we'll be covering is kind of what the ketogenic diet looks like. So at a glance, we know that the ketogenic diet is going to be a very high fat, adequate protein, and a very low carbohydrate diet. What we mean by adequate protein is that typically we eat a lot more protein than what our body needs, and we're restricting that amount to just what our body needs. Like stated before, it is a medically supervised diet, so we really want you to associate the diet as a medication. We know it's an effective treatment for epilepsy, and typically it's used after a few anti-seizure medications have been trialed and haven't been successful. And what we really want you to know is that it's used for all ages, so babies all the way to adults.
Quick little break. There's 3 seats up front, there's 2 on the side over there, and there's a few off to the side. Please walk up to have a seat. Yeah, no need to stand in the back taking notes. Okay, so, I've been seeing a lot on magazines and books in the press and television about people using ketogenic diet to lose weight. So can you tell me, is this like that diet? Can I follow those things that I see like in books and magazines?
So the diet is very different. So again, it's like a medication. So we know that it's going to be very different than what I call the Google version of keto. The goal is not to lose weight. So with that being said, the calories are not going to be restricted. So if your child is put on the ketogenic diet, we still want them to grow according to their growth chart. And what we really want you to know too is that the majority of calories are coming from fat. And yes, the Google version of keto is a high-fat, low-carb diet, but the ketogenic medical diet can be as much as 90% of your calories coming from fat. So a huge difference between the two. Again, also, it's not a very high-protein diet, so it's providing just adequate protein because protein by itself can be converted into sugars, which we don't want for our body since we want to keep that amount of sugar in our diet very low. So that's why I restrict the protein. And then typically also most sugar alcohols on the Google version of keto won't be allowed on the medical version of keto. And that's because most sugar alcohols still contribute to your blood sugar by a small amount, and that small amount will count for the medical ketogenic diet.
Okay, so I'm understanding that what I look up online might not be the right thing. So is there one right way to do ketogenic diet for seizures?
So there's several different ways to do the ketogenic diet. In general, there are 5 main types of diet. So going over them very briefly, the most common one is the classic ketogenic diet. This one's prescribed in what we call ketogenic ratios, which I'll review a little bit over in a little bit. And you're using a gram scale to prepare all food. You work very closely with your dietitian to help create these very specific recipes. The next type of diet is called the modified Atkins diet, or MAD for short. This diet, you're just tracking net carbohydrates, but we encourage a lot of fat in the diet and to eat fat until you're satiated. Next is the modified ketogenic diet. So it's almost a combination of the classic ketogenic diet and the modified Atkins diet combined. So you're using the concepts of a ketogenic ratio, but you're not just tracking your net carbohydrates, but you're also tracking your fat and your protein intake as well. The next diet is called the low glycemic index treatment. This type of diet is a high-fat diet, so about 60% of your nutrition is coming from fat. It allows more carbohydrates, so about 40 to 60 grams of carbs, but what you're looking at is really what type of carbs you're eating. So we want those carbohydrates to only come from low glycemic index foods, so with the glycemic index below 50. And the glycemic index basically describes the effect of a food on your blood sugar. For example, if you drink a cup of juice versus eating a fruit, the fruit has fiber in it, so the impact on your blood sugars is lower versus if you drink straight juice. Finally, the last type of diet is the MCT oil diet. This one allows more carbohydrates in the diet because MCT oil helps build a little bit more ketones for yourself, so it can allow for a higher carbohydrate, and typically it's about 30 to 60% of your nutrition coming from MCT. That being said, 5 categories, but you and your ketogenic team may come up with a combination of all of them. It really depends what fits you, your type of diet, your type of lifestyle, all of that put all together. So now we're just going to show you a couple of pictures, kind of showing what the most restrictive, which would be the classic ketogenic diet, looks like versus a more liberalized version such as the modified Atkins. These pictures here show the classic ketogenic diet, and they show all the different ketogenic ratios. So in the green circle, you'll see a ketogenic 1-to-1 ratio meal. What the 1-to-1 ratio really describes is for every 1 gram of fat, you have 1 collective gram of carbohydrates and protein. So here you'll see the plate has broccoli, chicken breasts, green olives, parsley, mayonnaise, and olive oil. On the other hand, you have in the red circle a classic ketogenic 4-to-1 ratio meal. So again, the concept of for every 4 grams of fat, you have 1 collective gram of carbohydrates and protein together. Here you'll see that there was a reduction of ingredients, and in general, when we visually look at it, those 2 meals look completely different in the sense that our 1-to-1 ratio meal looks a lot fuller versus the 4-to-1 ratio. The caveat to that is that both of these meals are actually 400 calories, so they're both the same amount of calories. The reason why the 4-to-1 ratio meal looks less is because we know fat is more than twice as calorically dense as a carbohydrate or a protein. So we know that the volume of food will look different. So yes, your meal may look smaller, but you'll really be getting the same amount of nutrition as you would on your regular diet. Next are some pictures of different modified Atkins meals. Again, the idea is that you're just counting net carbohydrates and then you're trying to encourage high fat. So here you'll see good fats such as avocado, chia seeds, heavy cream, flax seeds, butter, cheese, and then you'll have some proteins and low carbohydrate alternatives.
Great, so you've talked me through a lot of different ways that we can do the ketogenic diet. But this is put together by a dietitian, so it must be a complete nutrition. Do I need anything else to supplement the diet?
So even though we are meeting all of your calorie needs, the idea is that, yes, you still need additional supplementation. And that's because if you take a step back and think about it, most of our vitamins and minerals are coming from sources of fortified grains, of fruits, and vegetables. So when we limit our carbohydrates, we're reducing all of that significantly. So we need to add back in these vitamins and minerals. So more likely than not, you'll be put on a multivitamin and possibly additional calcium vitamin D just to meet your micronutrient needs. We also need to make sure that all of these supplements are low in carbohydrates. So typically, pill or tablet versions are recommended, as liquid or chewable versions contain a lot of carbohydrates, and we're trying to reduce the amount of carbs in your diet. We also know that the diet may have some side effects, so some of those side effects need to be treated with additional supplementation too. And the finally last piece of it too is that the supplement industry is not regulated by the FDA largely, so we want to make sure that you're working with your dietitian, your healthcare providers to make sure that you are taking a safe supplement. So in addition to the calcium and vitamin D and the multivitamin, other supplements may be included would be MCT oil, and that's to help promote ketosis. Carnitine is an essential nutrient to help metabolize the fats, and since you're on a high-fat diet, you may be using a lot more carnitine than what your body needed on a regular diet, so this may be supplemented in. Bicarbonates and citrates are used to help buffer the blood because the diet itself is acidic, so we need to help buffer that out. And then the last couple, soluble fiber and omega-3, will help correct the lipid panel. As we'll talk about side effects later, there could be elevated levels in your lipid panel.
So you talked a lot about different kinds of foods, even taking extra pills and supplements and vitamins. So I assume that if I have a baby who's still nursing or feeding formula, or a child with a G-tube, then it must not work for that, right?
Actually, it works perfectly, and the reason being is because there's a ton of different keto formulas on the market now. This can be used for your tube-fed child or yourself, or it could even be drinking by mouth. I've actually tried all of the keto formulas myself, and I'm not on the keto diet, and they all taste great. The other idea too is if you have a tube-fed child, we can also do keto blenderized diet as well. So taking real food, blending it up, or even doing a combination of the two. So doing part keto formula with part food, that can also be done. If your child is breastfeeding or still nursing, we can also do a combination of the diet. So we could do a modified version of the breastfeeding where we're incorporating ideas of an MCT oil diet and supplementing MCT oil to promote ketosis, while also layering in possibly some bottles mixed with keto formula and breast milk to create a ketogenic ratio. So it could be a combination of all of those things. And then if your baby starts to solids, we can ultimately mix some fat in with the baby purees in order to create a ketogenic meal as well. So in general, these types of patients would be started on the classic ketogenic diet, and we have seen that there's really great tolerance and really good adherence to the diet because everything's structured to a ketogenic ratio, everything's proportionate as well. Typically, though, this is done during an inpatient admission, and that's because we want to ensure there's really great tolerance with the rapid change in the diet, and we want to make sure to monitor and treat any side effects that are happening. This also provides a really great opportunity to work with your keto team to get really good in-depth education so that you feel like you have the tools to implement this at home. Because there's nothing worse than you going home and feeling like you don't have that, that support right there as well. Infants specifically, these patients typically end up at a lower ketogenic ratio, and that's because they are more prone to low blood sugars.
So you just mentioned starting in the hospital. Is that part that's necessary all the time? You have to start in an inpatient setting?
So no, you can actually start a few of the diets at home. So there's 3 different categories right there. The first one is some of the diets always start at home. So that would be modified Atkins, the modified keto diet, or the low glycemic index treatment. The other idea for other types of diets, such as the classic, is that we can do a low and slow method. So we wouldn't do a rapid progression of getting onto the diet, but we would take it slower, outpatient, monitor how you're doing, and adjust accordingly. But overall, we just want you to chat with your team, figure out what's the best method, what would be the most appropriate, what would be the most tolerable, and we can all decide that together. Can we take questions at the end if that's okay? Sorry about that. So two pieces. So first piece would be the inpatient method. So typically we are starting at a lower ketogenic ratio, and then we're increasing and titrating as tolerated and based on how labs are turning out. So part of that would be getting labs to monitor your electrolytes, your acid level, and your ketone production, and your blood sugar. Like we stated before, you'll be going through pretty in-depth education, and then you'll be getting that close monitoring in the hospital to make sure that you're tolerating the diet, there are no side effects, or if there are side effects, then we're treating them. And then in general, you'll be working with a very comprehensive interdisciplinary team. So you'll have your neurologists, we have nurse practitioners or PAs, we have pharmacists that work well with us, dietitians, and even social workers that also work to help make sure that you, again, have the resources you need to be successful in the diet at home. And biggest piece of it is we want to work with you and your family, because they're going to be the people that help make sure that the diet goes well at home. So we want to come all together, have a family meeting, and make sure that we put you in a successful route. So, Dr. Fong, is this considered a natural treatment, and can I get off medications?
You know, that's a common question that we get, because obviously people are looking for treatments to help treat the seizures, make the seizures go away. But there's usually a second goal, which is to reduce medications and reduce side effects that are associated with medications. So I get that question quite often. And, you know, the short answer is that we do use it together with medications, but that there are some situations where you may potentially be just on the ketogenic diet and off of medications. This is a very case-by-case scenario, and it kind of depends on what kind of epilepsy you have, what the underlying situation is. In general, though, as we mentioned earlier, with Dr. Rathke mentioning earlier, that we do start it on patients who have already been on medications. The common setting is that you've already tried and failed probably 2 or more medications. And so think about it just like when you start a new seizure medication, right? When you start a new medicine, let's say you're drug number 3, you're not going to cold turkey stop drug 1 and 2 and start number 3, right? Because what if you start number 3, you don't tolerate it, you have to come off of it. Or you start number 3, it doesn't work for you, right? So we don't want a situation where we've taken everything off before anything's even on. But just like with meds, if you start a new treatment and the seizures go away, you get to a seizure-free point, what do we try to do? We try to reduce the other meds that were already there before, right? And we would do that stepwise, 1 drug at a time. You don't cold turkey stop anything. But we would start to decrease 1 medicine, then if you get off of 1, maybe another one. So you could potentially get to a situation where you're just on the ketogenic diet. But it's, you know, the simplest implementation, it's in addition to supplement medications that you're on, and then to hopefully help you reduce medications afterwards. Now, we do use this together with other therapies as well. So you may have a VNS or an RNS or deep brain stimulation. These are other neuromodulation techniques, right? You may be in the middle of going through an evaluation for surgery. That's okay. We can use it together with all of those things as well. You heard earlier, it's when used in the right way, it's fairly effective. One of the other reasons that we typically say it's after 2 meds have been tried is because, as you heard earlier, that what's the chance that drug number 3, 4, 5, drug number 10 is going to make you seizure free? That chance gets smaller and smaller and smaller over time. And so once you've failed 2 medications, the chance that something different might be helpful for you becomes much higher. And so that's when we look for other options like surgery, neuromodulation, and of course the diet as well. About 2/3 of patients who start the diet or some form of the diet, it'll significantly help reduce their seizures. But just like with any other thing, right? Something that works for one person might not work for another person. So about 1/3 of patients who try the diet, it just won't be effective for them.
So if I feel ready to start the diet, can I just start?
Great question. There are some patients for whom it works better, and there are some patients for whom it actually is not safe. It's contraindicated. As you heard earlier, we're changing how our entire body gets energy, how it functions metabolically. And we need to make sure that your body has the mechanics, the tools necessary to be able to metabolize fat for energy. And so there are some situations where it might not be safe for you. There are a subset of diagnoses, so you don't have to be able to read all of that, but there's about a dozen diagnoses that you see up there in Table 1. Those are epileptic syndromes where we know that it seems to work particularly well. And so in those patients, we do want to try it really early. and you have a slightly better chance that it's going to be something meaningfully helpful for you. So, in terms of whether you can just start now that you feel ready, I would say absolutely not. You need to talk to your doctor, talk to your ketogenic team, figure out a regimen that works for you, make sure that it's safe for you before you start. And in the way of contraindications, again, there's a list of diagnoses up there where in those situations, it would not be safe to do the ketogenic diet. So we do make sure that you don't have one of those conditions before you start the ketogenic diet in any form, even the modified Atkins. So there's baseline screening labs to make sure it's safe for you to do the diet. And then once you're on the diet, we have regular labs that we check. And then you'll be monitoring those labs along with your ketogenic team and then talking about side effects and things that come up in your visits moving forward.
So because food is natural, this is a natural diet and there aren't any side effects, right?
I would love for that to be true, but it's not. I tell people really think of the ketogenic diet as a seizure drug. It's not any different. And that means that it works for some people, doesn't work for other people. And it means that there's potential side effects. But not everyone has every side effect. Somebody might have no side effects. But it is important to know that there are potential side effects. Some of those side effects are more around in the beginning when you're starting, and the more aggressive you are in your starting, the higher the ratio, classic versus modified Atkins. Some of those things increase the chance of these acute side effects, and that's why in some settings we choose to start patients in the hospital so we can monitor for all of those things. And common examples of those include dehydration or low sugars, low glucose. And if that happens, you might get very lethargic, shaky. As you heard earlier, the ketogenic diet is an acidotic diet. It makes your body become sort of an acidotic environment, and it could become overly acidotic, and that would be a problem too. That's called metabolic acidosis. We watch for weight loss, which is the more common thing that happens, and that makes sense then why some people use it as a weight loss diet. But you can also have weight gain, and the most common thing is just GI side effects, upset stomach, reflux, vomiting, diarrhea, things of that sort. So we're watching for all of those kinds of things and helping you, control that. Imagine that you're on a diet that is your medicine, right? And you start having really bad reflux and vomiting, and now you eat your lunch and then you vomit your lunch. Well, that means you didn't get your medicine. Make sense? And so from that point of view, thinking about the complete picture of the patient, how is their, if they're tube fed, do they tolerate the tube feedings? If they're eating by mouth, can they manage to get all of this down? If it causes you a lot of discomfort, you're going to stop it. So how do we help control those kinds of side effects? Those are all things that we think about early on. And then in the long run, if you stay on it over a long period of time, there's a different set of side effects that could potentially become an issue. And we monitor for those things. So we know that there's decreased bone density that could happen with long-term use of the ketogenic diet. And we do things like vitamin D and calcium and weight-bearing recommendations and, to help mitigate those things. And then there's low carnitine. So carnitine is something that your body uses in order to efficiently use the diet and to generate energy from the diet. So you sort of deplete those sources and you can run low on them. And if you're low, then the diet's not as effective as it should be. So we monitor for things like that. And of course, you're eating a high-fat diet. So, you can think of just things you know about your own health, right? A high-fat diet means higher cholesterol. So we watch for things like that. Cholesterol does go up a lot in the beginning when you start the diet, but the longer you stay on it, it actually comes back down and either normalizes or gets close to normalized over time. But we watch those things to make sure that, you have a healthy profile of cholesterol. And then lastly, kidney stones is something that used to be fairly common, but now we have medications that can help reduce the chance of kidney stones. So you may be on extra prescriptions if that's necessary, in addition to being on the diet. So as you've heard, there's a lot of things that we need to watch for, and that means that there's different types of monitoring that we do, and it's a combination of these things. And depending on the program that you're working with and your specific, diet regimen, you're going to have different guidelines for how you're monitoring and what you're monitoring. But it's a combination of monitoring that's done at home, monitoring that's done by going to the lab and getting blood draws, and then discussing side effects and things together in clinic. So the monitoring that you do at home may be in the way of urine checks. So they're the little strips that you dip in the urine and they turn different colors to monitor your ketones, for example. Or you might have actually a meter where you poke your finger, just like diabetic patients check their sugar, and it looks exactly like that. And you might be given something like that to check your glucose and your ketones. And then the regular labs that you get drawn at the laboratory, you'll have a set done before you start to make sure that it's safe for you to do it, as we talked about earlier. And then we always check a set 1 month after you start the diet, 3 months after you start the diet, to make sure that we're adding in whatever supplements become necessary. Those things will get tweaked up and down based on what your labs are showing us. And then as long as you stay on the diet, we'll keep checking labs every once in a while, at a minimum once every 6 to 12 months.
So, if I don't feel like the diet is working for me, do I have to stay on it?
No, absolutely not. Just like with seizure medications, right? The medicines that are not working for you, we should try to get them off, because all medications, including the ketogenic diet, can cause side effects. So I don't want you on an extra treatment that's not doing you any good. But it's just like you can't stop your seizure medicine cold turkey overnight. You also can't stop keto cold turkey overnight. So once we've got you up and running on a diet, if you decide after a few months that it's not working for you, we will gradually wean you off in the same way that you would wean off of a new seizure medication, for example. We do ask people to give it 3 months to really get a good idea of the full capacity of the diet to help you, because it is such a big shift that we're making on your entire body and how it's metabolizing that we really need to give it that amount of time to get a good sense. But if it doesn't work, then your team should help you to come off of the diet. One last thing I do recommend, though, is if you've tried it in the past and it wasn't effective then, it may be worthwhile to think about potentially trying it again at another time. Why might that be? Well, maybe you had a little bit less guidance before, or maybe you're on different medications that were combining to make side effects that you're on a different med regimen now. And sometimes, very early on as a baby versus later on in adulthood, things that didn't work before may work again in the future. But that might be not the case if you had a horrible side effect from it the first time, and it might not ever be recommended to try it again. So it's always worth discussing with your team to ask, hey, I did tried this before, it didn't work that great, but we're running low on medicine options. Is it worth thinking about doing it again?
So what are my next steps?
So if this sounds like something that's of interest to you, start talking with your team, talk to your doctor, talk to the dietitian, get into the keto clinic. And it's initially a consultation to see what is it that you're doing now, how might this help, is it safe for you to do, and then you work from there to put together a program that's individualized to you.
Thank you for your time, and we'll take questions now.
So I would say that you're at a good place, and maybe you should just pause there for a little while and stay in a good regimen. Think of it just like with medicines, right? If you got to some combination of treatments where you finally reach seizure freedom, you kind of want to just not rock the boat, right? Just stay calm, keep things quiet for a little while before you then think about trying to reduce things. I would say if this continues, eventually there should be a talk about trying to reduce, if there's medications on board, reduce medications. And then talk about how long you stay on the diet, depending on how long you think your epilepsy may be around. If there's a potential that you outgrew it, then it's worth evaluating that. Or if it's something that you know is not going to be outgrown, then you have to think of a combination of some treatments that you're going to sustain and stay on. That might be diet alone, that might be diet plus a medicine, or it might be down the road, you're seizure-free, doing great, but maybe you're on just a low dose of medicine, you want to get off the modified Atkins diet now, have a more regular diet. Those are all possible options. Will not work, is that what you said? There isn't any one particular medicine that we say cannot be done with the ketogenic diet. There are some things to think about, like the formulation that you're taking. So anything that's in an oral solution, except for Epidiolex, which is an oil, but all of the other, Keppra, Onfi, all those things that are in liquid form are in sugar solutions. So you'll need to come off of sugar solutions onto usually tablets that are ground up or tablets that are taken whole, depending on the patient, right? So there's those kinds of things. Some medications do have overlapping side effects. It doesn't mean you can't be on it. It's just something to be aware of and watch for. So for example, all the carbonic anhydrase inhibitors, so the topiramate and the zonisamide, those have their own risk of forming kidney stones. And I said ketogenic diet has a risk of forming kidney stones. It doesn't mean you're guaranteed to have kidney stones if you're on both of those things, but it's just a higher risk. So it's, things that you're going to be watching for. Yes.
So are you guys recommending like organic fruits and vegetables, organic meat, organic vitamins? Because there's so much junk out there nowadays. So even when you eat your fruits and vegetables on the diet, if you're not on organic, it's not really beneficial to your body, is it?
So in terms of organic versus not organic, I don't make a particular recommendation because I try to be mindful of everyone's financial circumstances. So it's whatever fits the family's, food philosophy goals and what they can afford. So if you are all game for organic and your family could afford it, then by all means go for organic. But
Is that the same for supplements?
yes, the same idea would apply for supplements as well.
And that's in the choice of supplements, of course, but if a supplement is deemed necessary, then it is necessary. But, which specific organic versus not, that's more flexible.
So you don't think there's truth in a $5 supplement versus a $25 supplement? One being better than the other?
I think in terms of price, it would be highly dependent on the company itself and if they're third-party tested or if they have CSP regulation and everything. Typically, your dietitian will review the supplement. So I can't say price-wise what the difference would be, but we do want to make sure that it is a verified source because there's risk of toxicity or, addition of like a different microbiome or something because it wasn't tested. So that's the main piece that we're looking at.
So I have one more kind of question that ties in. My daughter already has a really low carnitine level, and I noticed up there on one of the slides it said supplementing it. So how do you supplement that? We've only been told to increase meat.
So when you're doing it with food, you can find food sources that have high carnitine, and meat is very commonly the way we do that. With pills and with, other supplements in that form, it comes in pill form, it also comes in a liquid form. So we can supplement, just like a vitamin as an additional supplement. Yes.
Can you explain why in the ratio you're going by grams of fat, protein, carbs, as opposed to the percentage of calories from fat?
Good question. Let me think this one out. I think it's because also we have to factor in the caloric density of everything versus the gram weight then creates that 90% of calories. So all of that is proportionate in a different way of thinking. Does that make sense?
And like, for example, like some essential calories, like carbs and proteins are 4 calories per gram of fat, et cetera, right? So like, it's
Yeah.
pretty equitable, you're saying?
So when you calculate the ratio, I think what you're asking is like, for example, if you're on a 3-to-1 ratio, that 3 means that 75% of your calories are coming from fat sources, and 25% are coming from all other sources, which is protein plus carbohydrates. And so, when we tell people though, like, this is how many calories you're getting, that would be a lot of math to have to figure out how many calories from my food. So when we give you your recipes, it's not in calories. I mean, there's a total calorie that you're getting, but what you're measuring as you make your meals is grams. So we say you need how many grams of fat and how many grams of carbs and protein, and that's what you weigh on a gram scale. So they're related. The ratios are dependent on the calories, but when you're practically doing it, putting a meal together, you're weighing grams, not counting calories. Yeah.
What about for the pregnant person that may be trying to get on a keto diet, try to wean off the other medications to potentially not affect the fetus? Is this
Great question.
typically safer than a medication that's fabricated?
I mean, that's a great question because, we have some data about seizure medications and safety for the unborn fetus when the pregnant mom is taking it, right? But we have so many of our drugs where we actually don't have that data available yet. So there are some meds where you can get very specific guidance, like valproic acid, don't do it. And, of the medications, lamotrigine is the safest. So there are things that we can say, but I just had a patient actually last week ask me about felbamate, which she's on felbamate, and we don't have the data. If I took a guess, I would guess it probably is not that great, but I don't have data to back that up. And we're collecting that data still over time. But in terms of for diet, I would say it's similar. We don't have hardcore data where I can say, hey, these are the numbers, thousands of people, these are the chances of X, Y, and Z birth-related, defects. However, I will say, just anecdotally, that there are patients who have GLUT1 deficiency syndrome, and you heard about that briefly earlier. This is a genetic diagnosis where your brain does not have access to the carbohydrates to make energy. And so we have to provide a different source of energy. And so ketogenic diet is the treatment for GLUT1 deficiency syndrome by providing fat to fuel your brain. Well, so these patients stay on some version of a ketogenic diet essentially for life. You can become less stringent over time, but some version of it. There is a mom a woman with GLUT1 deficiency syndrome who became pregnant, and she stayed on a modified Atkins diet during her pregnancy, and she delivered a baby who also has GLUT1 deficiency syndrome and is not a baby anymore, actually. And that patient, that child not child anymore either, sorry, adult now, but that person has not ever had a seizure. So, and this is one person, right? So I don't have the scientific data to say this is just as safe as lamotrigine or anything like that. But there are cases of, pregnant women who have stayed on diet and the babies have been okay. And we put newborn babies in the NICU on the diet. We will even use it for preemie babies sometimes. So from that point of view, I would say, we are using it in very, very young babies. I would, given the choice of meds that we know nothing about versus diet, I would lean towards saying probably diet is safer, but this is not based on strong data. Yes.
For the survey and the seizure information on it, what can you talk about the long-term potential benefits and seizure reduction with time, and if that increases or
Yeah, as you heard earlier, patients who respond tend to respond pretty quickly. Some people you can tell within days that they're going to be better. Like you see a noticeable difference days after starting the diet. Some people take a little bit longer. Some people you might need a month or two to get a good sense. But if you stay on it because it seems to be working, then, there's plenty of patients who stay on it for many, many years. Over time, as I said earlier, oftentimes you can be a little bit more lax. So maybe in the beginning you might need a high ratio, but after you've been on it for a few years, you might be down to a modified Atkins because you're able to sort of decrease it over time. And you heard earlier that, we don't really understand it fully, but we think that it might be just helping the brain environment, right? Decrease inflammation and all of these kinds of things that help sort of potentiate less seizures over time. So there's a lot of examples of adults who are sustaining, started as a ketogenic diet as a child, but are now sustaining on a modified Atkins diet. So, any other questions? Thank you. Oh, yes.
will there ever be a way to get keto formula without a prescription?
In terms of, because the keto formulas that we talked about are what we call complete nutrition sources. So they're designed for not only drinking, like, drinking a Pediasure with your meal, for example, but they're designed to be sole source nutrition. So because of that, they are a medically formulated formula. There's other ways that we can make supplemental